So this is an approach to gram-positive cocci. This is meant to be a beginner approach to this, and it is divided into two parts. Gram-positive cocci can be divided into those that form groups or clusters, the Staphylococci, those that form chains, the Streptococci, as well as those that form pairs and short chains, the Enterococci. When we look at groups and clusters, the way that they name this may depend on where you work. We can further subdivide this into those that are coagulase positive and those that are coagulase negative. Now, I'll do a quick thing about coagulase negative Staphylococci, but an in-depth discussion is probably beyond the scope of this lecture. In general, they're very indolent organisms that cause hardware-associated infection or line-associated infections, with the exception of one, which is Staph lugdunensis. When you see this, I want you to think about everything you would with Staph aureus, okay? When they're coagulase positive, that generally, in a clinical sense, means it's Staphylococcus aureus. And we'll discuss more about the syndromes that can cause next. We sometimes think about Staph aureus in terms of its sensitivity to different antibiotics. There's methicillin-sensitive Staph aureus, also known as MSSA, methicillin-resistant Staph aureus, MRSA, and a couple of other ones, which I'll only go briefly into, Vancomycin intermediate Staph aureus, as well as Vancomycin-resistant Staph aureus. Staph aureus can cause a variety of different syndromes. The most common ones being skin infections. This is often purulent cellulitis, bacteremia, endocarditis, prosthetic joint and device infections, as well as pneumonias. For serious MSSA infections, you should be using cefazolin or cloxacillin. I do want to make a quick note that there are Staph aureus isolates that are sensitive to penicillin. This does become an option in those circumstances. However, this is not altogether that common, and on top of that, many labs actually don't test or report this. So I think for simplicity's sake, I would focus on remembering that cefazolin or cloxacillin are the agents you should use for MSSA serious infections. To consider between the two agents, cefazolin has the advantage of being 3 times a day dosing, as well as being a little more tolerable, but at least traditionally is not thought to have blood-brain barrier penetration. When you want to penetrate the CNS, you do need to use cloxacillin. Cloxacillin is advantageous because it does not require renal dosing, so if you're a patient with tenuous renal function, this can be useful, but it can cause thrombophlebitis, as well as it requires 6 times daily dosing. There are a variety of oral options for MSSA. These include cephalexin, cefadroxil, which I think of as cephalexin but just dosed twice a day, amoxiclav, cloxacillin, and other higher generation cephalosporins. Now, you might be wondering a little bit about the amoxiclav. That is because MSSA resistance to penicillin is generally mediated by a beta-lactamase, and the clavulinate component of that can help overcome that resistance. However, amoxiclav is a little bit broader and shouldn't be used unless you need to for some other reasons. Options for MRSA may also work as well, and I'll discuss those in a bit. For MRSA, they have alternative penicillin binding proteins with a lower binding to beta-lactams. Therefore, it's resistant. There are similar syndromes to MSSA. For IV options for serious infections, you can use vancomycin, daptomycin, and ceftobiprole. I'll speak a bit more about that in a second. Oral options can include doxycycline and Septra, but remember, pregnancy is a contraindication due to teratogenicity. Clindamycin, but here remember that it is not reliably sensitive to clindamycin, so you do need sensitivities. And linezolid. Remember that linezolid can have an effect on your bone marrow, and you must watch a CBC to ensure that there's no suppression of the marrow. For the treatment of invasive infections or serious infections, for the most part, you want to be using IV antibiotics. So for vancomycin, but remember here that surfactant in the lungs will deactivate daptomycin, so you cannot use it to treat pneumonia. And a newer option includes ceftobiprole, which is a fifth generation, fairly broad spectrum cephalosporin, which I'll talk to you more about in a second. The Eradicate trial showed that it's comparable to daptomycin in its ability to treat MRSA, but it is a very broad spectrum antibiotic, and for now, I would stress that to remember vancomycin and dapto primarily. So vancomycin intermediate Staph aureus happens when MRSA continues to thicken its cell wall to make it harder for vancomycin to penetrate. This is interesting because the cell wall is also responsible for many cellular functions, and this is a very unfit organism that never persists in nature without continued selective pressure. For vancomycin-resistant Staph aureus, it has the VAN-A gene, which makes it fully resistant to vancomycin. For both Visa and VRSA, it's not clear what the best options for therapy are, but in general, you might want to consider combination therapy, and some options may include daptomycin and ceftobiprole. Not necessarily in combination. So next, let's move on to the Streptococci. You may have heard of an approach of Streptococci where we talk about hemolysis. I find this approach to Streptococci a bit more beginner-friendly, but you can decide for yourself what approach you would like to take. I kind of just group the Streptococci into various groups that cause different syndromes. So first is group A, B, C, and G strep, primarily focusing on group A strep, strep pneumo, strep bovis, and strep anginosus. The last two just being little tidbits that are important for exams in certain clinical scenarios. Group A strep is the most common cause of non-purulent cellulitis. It can also be the agent behind monomicrobial or type 2 necrotizing fasciitis, and this is sometimes associated with toxic shock syndrome. But you should remember that group B, C, and G streptococci can also have the toxin and cause toxic shock syndrome. I should also mention at this point that although group A strep is the agent behind this, it does not always cause necrotizing fasciitis. And it can simply be causing your run-of-the-mill non-purulent cellulitis as well. For toxic shock syndrome, you'll remember that you want to treat this with vancomycin, piptazo, clindamycin, and IVIG. And I should explain each of these in sequence. For the vancomycin and the piptazo, the only reason that medical schools tell you to treat them like this initially is because before cultures are back, patients are often very sick. To ensure you're not missing an organism in a very sick patient, you've applied very broad spectrum therapy. However, once you know that it is group A Streptococcus causing this, and only group A Streptococcus causing this, there is no advantage to using piptazo and vanco over simply penicillin. You'll also remember from your medical school lectures that you may be using clindamycin as well as IVIG. The reason behind the clindamycin is firstly, it's a ribosomal antibiotic. The toxin is a protein, and so there's an inhibition effect for the toxin. But what some scientists believe is actually more of the benefit is something called the eagle effect. So when bacteria get very, very dense, they start inhibiting each other in reproduction. This means that cell wall antibiotics don't work as well. Ribosomal antibiotics will inhibit the function of these existing bacteria and cause them to get out of the plateau phase of growth into a logarithmic phase of growth so that they're multiplying very quickly. This makes the beta-lactams more effective. Finally, IVIG helps bind up the toxin.